Welcome to the Pain Options Education Channel. I'm known as Darren.
And I'm Tim.
Nice to see you, Tim.
You too, Darren. It's been a little while.
It has been a little while, and it's good to see Judith here with us today. So welcome everyone to the Pelvis series, and this is the bigger picture, and we're delighted to have Judith here today to share her expertise and knowledge in this area with us and with all of you out there watching.
Very good. So Judith is a specialist. Now the terms have changed. We used to say women's health physio. What do we say now, Judith?
Pelvic health is more inclusive because we don't only see women, we do see men, and so it's sort of more inclusive.
Yeah.
Very good. And you're at the Body Logic Pelvic Health Clinic?
Yeah.
In Perth? Yep.
So about Judith, so we're going to get Judith to talk about herself, but I'll speak first. So it's a delight to have you here, Judith, and we've been on this journey a little bit together. I remember doing our PhDs at the same time in similar areas with a bit of crossover in methodology there. But yes, Judith is a specialist physiotherapist, as Tim mentioned, but also has a PhD and continues to do a lot of research in the area of pelvic health. I think more than that, you created the postgraduate course here at Perth, really, and been an inspiration to hundreds of physiotherapists that have come through that course to become pelvic health physiotherapists. So it's great to have you here and hopefully inspire a few more people.
Yeah, well, thanks for both of you for inviting me. I've really enjoyed working clinically alongside you, and I think that's where this has sort of come from, hasn't it? The overlap that we get between the pelvic health staff and the mus staff. We're always chatting and cross-referring, so I think that's a nice place to...
Yes, and we've all had the experience of working in multi-disc practices, so that's been nice. So to come here and talk about it would be excellent.
Yeah, the start of the pelvis series that we've done so far has really been from a musculoskeletal pain perspective around pelvic girdle pain, and that's the typical things where people think about with sacroiliac joint pain or pain around the symphysis pubis region, but more of that musculoskeletal pain. But your work, Judith, is certainly broader than that. You are involved in treating people with those conditions, and then we've had crossover where we work with people with, for example, with comorbid low back pain as well. But one of the common questions around what's the difference when people talk about pelvic girdle pain versus pelvic pain and perhaps broader pelvic health?
I think there are a lot of crossovers. Some people can present with a musculoskeletal, pelvic girdle pain, SIJ dysfunction, pubic symphysis dysfunction, and maybe some pelvic floor dysfunction. So really, as pelvic health physios, we come from thinking from the pelvic floor side of things first. So we're also doing a more in-depth interview into bladder, bowel and sexual health, and for women also that hormonal health and those conditions and how they impact pelvic girdle pain. And there are a lot of comorbid conditions such as irritable bowel, endometriosis, painful bladder syndrome, hormonally driven pelvic pain that we're always thinking about, and asking those more in-depth questions may reveal that there's something else going on, as well as the maybe the sacroiliac dysfunction. There may be other things going on in the pelvis.
Yeah, I certainly remember from a time when we worked together clinically where we would have a crossover of patients, an example being a low back pain patient that I might be seeing, or the other way around, you've seen someone for a more broader pelvic health issue, whether that's a continence issue, for example, and they had back pain which you referred to me for input, and things that you documented or picked up on, I wouldn't have been aware of at all in terms of either asking those questions or having information about that. So that's where there was that clear, I guess, additional strength and a whole range of other, well, it certainly taught me a lot around considering or learning more about these factors that I might not be involved in treating directly, but could certainly be involved in their overall clinical presentation, for example.
Yeah, I think, continence issues and low back pain are both very common conditions, and they're often comorbid, so often asking extra questions, and I think that's where we got to chatting together and skilling some of the mus physios to ask a little bit more about about continence issues, but also pain with intercourse, pain with sexual function, and bladder and bowel issues, sort of reveals that, okay, there may be a little bit more going on here. We could maybe talk to the pelvic health physios and see if there's... and often people are really very grateful often to find that there is help for these issues,
Yes.
which have often been quite private, and I constantly in my daily work find people that I didn't know I could get help for this. And so I think asking those extra questions, some people feel a little bit embarrassed at the first thinking, oh, am I skilled in this area? But actually people are really grateful that somebody's cared enough to ask.
Yeah, I always remember, as a musc physiotherapist, we ask about bowel and bladder in terms of quarter equina kind of disorder, which is a nice opener kind of question, but it's not enough detail really in that question for people to open up, because they might have slight disorders that they don't equate to that larger question. So I think it's quite important.
Yeah, and some people think it's normal to leak.
Yeah, exactly.
And some people have always had constipation, and it's just a family thing we always put up with, so they don't see it as abnormal or treatable, or to have any influence on their pain condition, which is the other thing.
I certainly remember with patients that we treated or worked with together, coming across in the case history, so information that you gathered, for example, that I wouldn't have asked or maybe didn't want to go there around, but it certainly alerted me to there's a level of questions or information that you can quite comfortably discuss with patients if they're coming in from a musculoskeletal pain perspective, like Darren said there, asking around bowel or bladder function more broadly in general. And when someone raises that as a really significant issue, since then I've had plenty of opportunities where I'm going, well, if this is an important issue, maybe you need some extra help, as you mentioned, and that flags that information for them, as you say, that they didn't even know there was help available.
Yeah, exactly. For sexual dysfunction as well, I think that's become a much more open discussion around that in the pelvic health arena. Mentioned a bit about women's disorders, but that's the change of name to pelvic health from women's health. Do you want to just mention about things you do with men these days? So
again, men can have pelvic pain, which is more penile, scrotal, testicle pain, and often is associated with more that increased tension around the pelvis. And again, pudendal nerve involvement. And so we see a lot of men that have sexual pain, pain with painful erections, painful with sitting, painful bowel actions, urgency and frequency with their bladder. But it may be really linked in with that back pain and pelvic girdle pain. So again, it's asking those extra questions, and that's often, I think, male pelvic pain is probably 10 years behind female pelvic pain. But definitely that's something, and I think the men are very relieved, because often it's dismissed as chronic prostatitis and not really treated. They're given antibiotics maybe, but not actually discussed as it might have a musculoskeletal part.
Yes.
Just on that, as a quick clinical tip, if you like, you talked about that term tension, where a lot of these symptoms are linked with tension.
Yeah.
How might you sort of alert or have a musculoskeletal physio be alert to this concept when they're seeing a patient, say, with back pain or other pelvic girdle pain, of the presentation there that might alert you to maybe these other sort of conditions or problems?
Again, I think, we do use the real-time ultrasound to watch the pelvic floor moving, and that I know a lot of practices have that, and if there is very little movement, that could alert you, but I think it's more in the history and the questioning. Often it's with bladder, it's that difficulty, some guys have difficulty with that flow. Painful erections, painful ejaculation, difficulty emptying the bowel, all the things that indicate maybe there's some extra tension there. So in the history, that may alert them. And then again, often just even watching on ultrasound when people breathe, if there's absolutely no movement of the pelvic floor, there's not even a bit of give as they're breathing, there's often a sign that there is some tension in that area.
Sure. So if I'm in the clinic with my back pain patient,
Yeah.
and their presentation is someone who is really guarded and protective, and
Yeah.
some of the treatment strategies I'm using for them is around breathing, relaxation, moving, increasing their cardiovascular exercise, and those things seem to be applicable or relevant to their back pain presentation. Is that sort of tense person or that type of presentation what you mean that might flow into this other?
Absolutely.
Yeah.
And often treating them that way may actually help their bladder and bowel symptoms, because but sometimes they need that extra help to sort of add those pieces of the puzzle together. But
Sure.
we often find that we need to treat their back pain as well as their bladder and bowel dysfunction, because the two are very comorbid.
I'm thinking of a few patients that I've seen that have had spinal surgery, and after that they have bladder or erectile dysfunction, and initially that might be screened or thought of as a neurological complication, which most of the time actually is fine, so then they're kind of left. So I think that fits back to this muscle dysfunction thing that you're talking about, and giving people another option around that's really important.
Yeah, and often just some simple biofeedback. People, a lot of men say, oh, I thought pelvic floor exercises were just for women, and weren't even aware that it is part of that core and understanding how to use the pelvic floor, not just turn it on, but to relax it. And if they've been given a lot of core training, they're often bracing through that area too.
Now, on the slide there's the term intraprofessional referral, and that's one of Darren's pet topics. He's been involved in sort of research projects around this nationally of late. What's your understanding of this there, Darren, or what do we want to know from Judith around that?
Yeah, well, I guess one thing we could say, in our practice here, we know most of our referrals don't come from physiotherapists, they come from other places where actually most of those people that come here referred from elsewhere are having physiotherapy, and the physiotherapist is struggling. So there's a bit of a problem with intraprofessional referral there in our field. Is that a similar case for you guys?
I think it is. As physios, we often, aren't doing that next step to actually ask for help of someone that's been doing pelvic health for a long time. There's a lot of people that are new to the area, and often I think telehealth brought an amazing extra thing that we can add, because we can actually, through telehealth, sit in on a consult with a physio and their patient and give that extra specialist advice. If people are struggling, it does, I think, maybe, I don't know, it might not be right, but people are perhaps worried about losing the patient by referring them on, or feeling that the patient might think that they don't know everything. But the patients I've had, and it's usually patients from country places, we've done a co-treatment. It's been really helpful. I've been able to sit in the room with the physio, who's in a remote area, so hasn't got access to a pelvic health physio. And we can just talk through things. I can say, can you check this? What about this? And that's been really helpful to give that next level of, which just comes with experience. I mean, I've been doing this 30 years, so again, you hear people's stories, you hear things that make sense, and helping other physios to with that patient can really be so helpful, and the patients are so grateful to have that extra person on board, I think.
Yeah, they don't disrespect the physio that's referring you at all. They
actually respect them more. So this is fantastic that you guys work together. This is great.
And do you get, at your clinic, for instance, many referrals from non-pelvic health physiotherapists? Or?
I do get quite, I think because I've done talks around, I get a lot from Pilates instructors, from chiropractors, and other, but physios probably is one of the least. But we do get some from other physios, and usually they're people that I have been involved in giving a talk or whatever they refer on.
There's kind of close contact there.
It's the close contact,
So I know this is difficult because there's such a range of conditions that you treat, but could you give any advice to physios out there, for example, or other health practitioners where they're seeing people with symptoms broadly in that area that might be good triggers or indicators for intraprofessional referral?
I mean, always the complex case is something anyone with pelvic pain, pelvic girdle pain. I think we are given a bit more information in undergraduate training and that but pelvic pain involving endometriosis, irritable bowel, painful bladder. A lot of those people have been seeing a physio for their back, and that they've never thought that there was something else they could do. So I think if people are presenting with multiple things, and they're often people with more maybe centrally driven central pain mechanisms, people that have also got fibromyalgia, endometriosis, but they might also have, back pain, hip pain. There's a lot of co-referring pain syndromes between hip pain and pelvic floor pain. And so I think, there's an opportunity that perhaps they could seek pelvic health physio consult to add to those complex cases.
So by the sounds, maybe part of the problem is some questions of the patient need to be asked of, do you have any of these range of symptoms, as you've mentioned there, because if the therapist is focused on their local pain problem as part of that, and that's not getting better, then that opportunity to step back and go, well, hang on, are there other conditions here? Ideally that would be asked at the front end though.
Yeah.
Is there any screening questionnaires around general health or those broader conditions in the area that easily come to mind, or is it developing a list of questions of possibilities?
We did do up a screening.
Moving on. Here's
I just need to know what we're talking about.
Oh, sorry. We have done up a psychological screening form, but we also did do some common questions to ask for screening with the Continence Foundation, looking at questions, but it was aimed more at Pilates instructors and those things to ask about bladder and bowel health that are available. But again, as screening tools, there are questionnaires that can be given on bladder and bowel health, but they're quite lengthy, and I don't really see people maybe using those. But I think just the question, we know that the pelvic floor is a really important part of the core. Do you feel you have had any issues with your bladder or bowel continence, or difficulty going to the toilet, any pain with intercourse or pain with sexual function? Those would be bladder, bowel and sexual health would be ones that would highlight. Have you talked to anyone about that? Do you know there are physios that actually deal with this area?
So that's kind of quick 3 questions worded quite succinctly there, that any physio could add into their consult that would alert you. And then the other part that we've talked about is the broader health conditions more involved in central type pain disorders, so the presence of those ones that you listed there, like around your endometriosis.
Endometriosis is a key one, because they're often the central pain mechanisms there. So if you're trying to treat a back pain, but they also have got endometriosis and a hormonally driven pain cycle, then you're starting to think about the central pain mechanisms and extra sensitivity. Again, irritable bowel is and painful bladder, both of those are very...
Then the other ones that musculoskeletal physio should be checking for anyway, such as broader fibromyalgia or other pain conditions such as migraine or TMJ. There are other signs that can alert you to something broader is going on beyond someone's other.
And they're usually the people whose pain hasn't settled with that initial bout of physio, and it's persisting, and you're having to think broader.
I like what you said before around, that explaining to the patient around the abdominal kind of cavity, and there's these different chambers around that. That's a really nice way a gentle way to broach these questions. That's less confrontational, which I think is really important for physios that aren't used to asking questions about this stuff.
And I mean the APA poster, which is the essential muscles for back support, includes the side picture of the pelvic floor. So I always pull that out and people go, I didn't even realise that was important for my back.
Yes.
And so again, I think that's one that general physios should have in their office and be able to refer, if we're talking about your core, we're not talking about your tummy muscles, it's that whole pelvic cylinder.
Good. So we've listed the 3 items on the screen there around your approach to your assessment, and we've talked a bit about this in terms of the screening tool side of things. How do you deal with that in your clinic? I think you said you do that before the patients come in.
So everybody is sent up front a thing that they can either fill out online or they do when they arrive at the office is just online. And we always screen for central pain mechanisms. We use the Central Sensitivity Index, which I know is a little bit controversial in that it's not diagnostic, but it's if they score over 40 on that central sensitization inventory, it's giving indications that you should be considering central pain mechanisms with this person, and that other things could be going on. And then we are now using the shorter form, the 3PSQ, which is something that we've developed at Curtin, which is the psychological pelvic pain screening questionnaire, which includes questions which we would have given out the DAS and the PCS, but this includes it all in one questionnaire, which we've developed. We're still in the validation process. But we do have found that that's useful in the clinic because it's much shorter. It's a 13 question item, and it covers what 11 questionnaires could cover, so it's shorter than that.
So you're screening there for
stress,
central sensitisation plus the more psychological domains around contributing
stress,
to pain?
Anxiety, depression, health anxiety, self-efficacy, fear, avoidance, and then there's the different aspects of catastrophization, rumination, magnification.
So you've covered those. Do you do other specific, either condition-specific or pelvic health specific screening, or do you deal with that when the patient?
We deal with that when the patient's there. Yeah. So because we have such a big range of people coming from incontinence, dysfunctional voiding, or bowel emptying problems, so they're quite different sort of, and then we see people before and after prostate surgery or gynae surgery. We also see pelvic pain, we see men, we see children. So we've sort of settled on that, so that we always start in that biopsychosocial, psychologically informed approach. There is a question both on the CSI and in the 3PSQ on trauma, because obviously trying to start in a trauma-informed way. If people have had a trauma, it could have been early life trauma, childhood trauma, or it could be in the pelvis. It's often, again, we're screening for any sexual assault, but also birth trauma as well for a lot of people, and very significant for pelvic girdle pain because it often starts around that time. And having a traumatic birth experience can be really significant in pain around the pelvis. So we screen for all those things, and I mean, it says, have you had a stressful or traumatic life event? So it could be a motor vehicle accident or anything, but we want to pick up that event that might have been impactful.
Because people might not have linked to those things themselves.
No. Yeah.
But that gives you a nice platform then, that, as you say, you've been psychologically and potentially trauma-informed
Yeah.
before you start. Not that you need to necessarily go into all of those details,
No.
but that helps set up the picture of factors
Yeah.
that might be relevant for
Yeah.
that person.
So it's really easy to start that conversation. You've self-scored yourself high for depression.
Yeah.
Do you feel that's a problem for you? Have you talked to your GP about it? Do you think that's having any impact on your pain that you're presenting with today?
Sure. What about the age-old argument that physiotherapists aren't psychologists? So people often
Yeah.
move away from we shouldn't be asking these things. How do you
But one of
respond?
the major things that we can do for depression is physical activity and cardio exercise. So it is in our domain to be understanding that that person has that comorbid condition, that I'm not going to be dealing with that specifically, but actually that's going to be really important to get them doing some cardio type exercise. And anxiety, we know that choosing some exercise that evokes the relaxation response and gives them some management strategies for that. They're the physical things we can do without being psychologists and treating that as such. We have good physio techniques that are important.
Sure.
And fear avoidance,
beliefs.
Beliefs. So setting, doing things in the clinic that they're fearful of and actually giving them that lived experience of change. Oh, I was able to bend without pain. Oh, I could get out of the chair without pain in my coccyx. If you give them that lived experience, that reduces the fear. So I think all those things are really important because we've got strategies to use to treat them. Yeah.
And we've talked about this in the past in other talks that we've done, that there's a difference there between that and someone that's got a significant psychological health issue that then requires either other medical or psychological support.
Yeah, and of course if we're revealing something that they've not talked to someone about, then obviously that's the first phone call or advice you're going to give them. I think you should make an appointment with your GP to discuss this, or have you reconnected with your psychologist? Like some people have been seeing a psychiatrist but then they've stopped that treatment, so it's important to pick that up and encourage them to re-engage.
Yeah, good. Other questions there, Darren?
No. Tim forgot his. Well, he thinks to get his clicker, he's just lost the.
I got one job and I couldn't do it properly. Anyway, we've talked a bit about the first one already.
Yeah, maybe we're going to shared management. So maybe I can ask both of you this because you have had those shared patients and you spoke to it a while ago. But I guess what things work well and make a shared management experience work better for you as clinicians and the patient?
Yeah, I think they're so grateful that you're actually taking care of their whole health, and you actually, to make this better, we're going to have to address your back pain issue at the same time. And I think they're very grateful. We've had some great results of actually addressing both issues, and I think if they're still in a lot of pain from more that musculoskeletal thing, then I'm not going to be as successful either. So it really is working together.
Yeah, particularly if you're trying to get someone to relax.
Yeah.
And their pain's quite high. And the other thing that I've found working with Judith in the past is she has brought up some concepts in the context of, say, some continence issues with the patient. And those same issues, like we've talked about, carrying too much tension or being really focused on their symptoms and not confident to move more normally, also applies with their back pain or their other musculoskeletal pain. And they might have been given that message, and then I might deliver something similar in the context of, say, their back pain, and then that can help them click that both messages are quite similar and people are talking around the same lines, or the other way around. I've said something but I really haven't either described it right or it hasn't clicked with them, and then Judith might be dealing with something around either sexual health or continence, and then that dual bit of information sort of shared
I think
differently.
it's always, it's much better to hear it from different sources, and if they can see a little video about it online and they can read about it, it's like, oh, everybody's saying the same thing. It really gives them that confidence.
Yeah.
So I try and give them a variety of options to read about it. How do you learn best? Is it best looking at a, do you want me to send you a little YouTube clip? Do you want something to read? Often I think hearing similar things from similar practitioners is really helpful.
Yeah, totally agree. The power of shared messaging is
yeah,
incredible.
It's just
I was thinking about sit-ups. I think some pelvic health physiotherapists are actually fearful of sit-ups. Maybe musculoskeletal physios sometimes as well. Where does the research and everything fit with this sit-up issue these days?
So, the thing is there are some people that doing sit-ups is creating a lot of intra-abdominal pressure, and particularly if they're postnatal and have that weakened fascial structure as well, then it could be that that's not a helpful thing for them. But we've all got to get out of bed in the morning. We need strength.
Exactly.
So sit-ups aren't a no-no, but they, again, if people are having prolapse symptoms, incontinence symptoms, that's often a sign that there is a weakness in the pelvic area. And doing a full pelvic health assessment, we can actually measure the pelvic floor, we can measure prolapse, we can measure the hiatus and how well they are at containing intra-abdominal pressure. And so we can give more specific instructions as to when sit-ups might be appropriate to reintroduce. And for some people, that might be never.
Yep.
Because they have had 5 babies and they've got a significant prolapse, and doing sit-ups would actually not be helpful for them in the long run. But for other people, they could be starting sit-ups and be absolutely fine with it. So it's really, with a proper assessment, you can give a clear answer, yes or no. And it isn't clear. Otherwise.
Of course it's based on the individual, but I think that's a good message for clinicians to hear around that.
Yeah, the other one on that is the squatting and lifting, because you'll often hear people say, I've got a pelvic floor issue, I'm not allowed to squat, or I shouldn't lift anything.
Yeah.
Assume the same spectrum applies.
There is, and some people it's absolutely fine. And there's a physio up in Queensland, Laurie Fauna, that's actually looking at prolapse in people that lift heavy. So she looked at CrossFitters and people that do, and there was no difference between the heavy lifters and the others. So it's not just the lifting, it's actually the technique.
Yeah.
And often if you're strong through your upper abs but weak through your pelvic floor and lower abs, then those are the ones that are going to create that downward force, which again, then they need to be, it's not you shouldn't lift or you shouldn't do weights, you should be coached properly to load, which I think it's the same with your back, isn't it?
Absolutely.
It's often, the other issue is the leg strength.
The leg strength is huge.
Yeah.
And I always say to the ladies with prolapse, you need strong legs, and actually be really working from the bottom to top rather than top down to bottom.
Yes.
That's
nice analogy.
Yeah. So I think it's very similar with your back support, because it's that whole pelvic area we need support. And so we've got particular people in the practice that are very keen to coach those CrossFitters and people that do want to lift heavy. Let's have an assessment, see for you individually, is that a good thing for you? How do we coach you to reach your goal?
Excellent. Well, I see the next thing on the list there's kind of around multimodal management. We've spoken a lot about exercise, about education and person-centered care as part of that. But there might be times when you need help.
Absolutely.
How do you guys do that?
Okay, well, again, I think it's usually, particularly in pelvic pain rather than pelvic girdle pain, but as I said, the two often coexist. Very much with bowel health and stuff, so nutritional health's really important
Right.
in anti-inflammatory. If we're trying to look at the pelvis and what's inflaming the pelvis, often if people have got irritable bowel and are very reactive to foods and stuff, we need to be looking down the nutrition pathway. So we work a lot with dietitians, nutritionists, looking at that side of things.
Excellent.
Again, sleep is really important. So we're always trying to see, can we co-manage sleep, which can be various strategies. It might be talking to the psychologist, it might be talking to the GP. As you know, my husband's a hypnotherapist, and so we use a lot of hypnotherapy as well, looking to manage sleep, because that's so important in pain. And then obviously the thoughts, all the thought-based therapies, what's right for this person? Is it seeing a psychologist? Is it doing CBT? Is it doing some mindfulness, going to yoga? What is it that helps calm that person's system? So that we're looking at that. And then exercise is the other big piece, and so we might be working with their PT or Pilates instructor, what's appropriate for them, because they should be exercising, but that's often some people are choosing the exercise that's flaring them up rather than settling them down. And what does that look like for them? So really working at that multimodal, trying to cross-refer to the people that can be there with them.
Excellent.
Yeah, but you'll also have that other whole group because you work with surgeons and so on as well.
Yeah,
so
of
you
course.
Get
so
that
we're working with the doctors.
Base.
I was thinking more of what I'm trying to get them to do for self-management care. But obviously, we're working all the time. You know, sometimes we assess people for something, particularly pelvic organ prolapse, which may need surgery as well. So then we have to prepare them for surgery and help them rehabilitate after surgery. Or working for with the surgeons and colorectal surgeons, and we've got a whole range because we've got urologists, urogynes.
So, from my experience with working with you and others, this is clearly an emerging field, and as you said, the men's health side of it's probably still quite a few years behind. So, I mean, there's great opportunity for progression of the profession.
There's great opportunity. And, the APA, you might know better than me, Darren, but they did tell me that it was the fastest growing special interest group after muscle and sport. So, and we've definitely seen that in the Curtin Masters course. It's a constant expanding of numbers.
And more men moving into that field a little
more
bit too.
Men, but we just don't have enough men. We want some more men, actually.
Tim wants to do some more training, don't you?
I need a bit more education.
I really see, in UK, the men's health is really taking off, and again, in Australia here it is too. But a lot of that, it seems a little bit siloed here. We did have one person come to do the Masters, and that's why, again, we were keen to call it pelvic health, because it isn't just about women. But there are a larger proportion of the course is about women. So that, again, I think people that want to just do men's health. So through the APA, we're trying to cater with that, with the courses, and sort of the structured way of trying to do blocks, and so they can build their career. But we definitely need more men in this area, I think.
Any more there?
Not from me.
I think that's pretty good.
Very good.
Yeah, we're pretty close to the end then. And did you have anything else you wanted to add, Judith, that we haven't spoken about?
No, I don't think so. I think we've covered good ground.
And I've been sitting here doing pelvic floor exercises, so if you rewind the video and see me pulling faces, you'll know what I was doing. So go back, viewers, and do that and count, then that'll be interesting.
Very good.
Otherwise, we're always open for questions at education@painoptions.com.au, or you could reach Judith at her clinic. Do you still,
we've
clinic email?
We're at pelvichealth.physio, so
there you go.
Again, you can find us and email us through that, or you can email me directly at Judith Thompson at pelvic.
There you go. And just a flag to specialist physio if you're looking for assistance with a a complex case, you'll find someone at specialist or physio that can help you, I think.
Yeah.
And as you said before, with telehealth being much more accepted these days, that's a great way to interact with people with more experience.
Yeah, and we can just be in the room with you as support to have that assessment to help out.
Yeah, that's some work, as I mentioned earlier, that Darren's been involved with the research team around looking at that shared care approach to treatment. So the treating physio might still continue the care, but that intermittent input from specialists to help guide that in the direction.
No, I think that's really helpful. Often people don't want to drive a long way to get to specialist care, so usually I'm trying to work with the local physio to actually facilitate that. Good.
So on the screen there we have a reminder of the rest of the episodes in our pelvis series. So flick back to those. Judith enjoyed them, she said. So,
I thought they were great.
So someone liked them. Since we did those prior podcasts, we've published this article now, Tim. So there's a reference for people to go back to, particularly related to pelvic girdle pain, but also does have some reference to some broader research in this area.
Yep, very good.
And where do we go? Oh yes, well, and we talked a bit about central sensitivity in these patients here, and we do have another series on pain sensitivity that people might want to check out.
Yeah.
Very good. All right, I think that's it. Judith, love your work as always, so thanks for joining us for this one, and hopefully the viewers find it useful. Yeah.
Thanks, Judith.
Cheers, everyone.
Bye.